So for an abdominal assessment, you want to start off like any other assessment and ask your patient any health history. Also what they do for a living and their daily life, because that can affect their abdominal discomfort. And then you want to start the exam with inspection. So you want to inspect color, contour, if there's any lesions, any scarring, any distension, the possibilities why there's distension, any hernias, which goes back to their daily life, their work, like you can associate that with that. And then you want to move on to auscultation. So when you auscultate, you use the stethoscope to listen to all four quadrants, bowel quadrants. And you use the diaphragm of the stethoscope starting in the right lower quadrant, working clockwise. So right lower to right upper to left upper to left lower. You're listening for bowel sounds which are irregular. There is no pattern to them. What you hear in one quadrant, you might not hear in another. It might sound different. There might be more, there might be less. And then if you don't hear any sounds, you have to listen for a full 5 minutes. So in total, for all four quadrants combined, you want to listen for a full 5 minutes in order to deem an absent bowel sound, which could be an obstruction or a complication from surgery or something like that. After that, you want to auscultate for the abdominal arteries, and you use the bell of the stethoscope for this. You start with the aortic, abdominal aorta, which is right below the sternum, and then you go to the renal arteries, and the renal arteries are to the sides, just like your kidneys are to the sides. The renal arteries are to the sides, and then the iliac arteries are below your belly button. They're not centered, but they're not as far to the sides as your renal arteries. And then the femoral arteries are on either side of the groin. So you would listen to the bell of the stethoscope for any bruits. Bruits are buildup of plaque, causing a restriction in the arteries. So after auscultation, you want to do percussion, and you would start by evaluating the liver size. So when you percuss an organ, you're percussing for the size of the organ, whether it's enlarged or not. So you start with the liver, and the liver has an upper and a lower border. So we're going to start with the lower border. You percuss it by tapping over your fingers and listening for a sound, type of sound. So you start in the lower quadrant, towards the side almost, and you percuss upwards. So when you're percussing in the lower quadrant on the right side, you're gonna hear tympany at first, because when you percuss the abdominal cavity, you hear tympany. So when we're percussing, we're gonna hear tympany, and as we move upwards, as soon as we hit the liver, we're gonna hear dull. When you hit an organ, you hear dull. So then to get the upper border, we start on top, and because we're starting high where it's over the lung fields, you're gonna hear resonance. And then we percuss downwards, and again hit the liver, it's dull. So tympany to dull and resonance to dull. And then after that, we do the same thing to the spleen, except the spleen only has an upper border, so it's gonna be resonance to dull for the spleen as well. Then we do blunt percussion. Blunt percussion is when you take your non-dominant hand and you cover the organ. So for the liver, we cover the liver, just like that. And then with our other hand, make a fist and you kind of just bang it. Not too hard, not too light. And this is for any sharp pains, any tenderness, that could be indicative of an abnormality or an infection of some sort. We do this for the kidneys as well. And same thing on both kidneys, cover it and bang it. Any tenderness or anything like that could be a kidney infection if you do have it. So it's very serious to make sure you do it properly. Then we palpate. So palpation, you don't want to palpate what hurts first, because if you do that, then the rest of your results might not be accurate because they're in pain from palpating the injured area. So you palpate starting off very lightly, just around the abdomen, just very light palpation, pushing down lightly, like no more than 2 centimeters. Then you move deeper palpation for more deep injuries or pains, and that's around 4 centimeters. Before you move on to the part that is sensitive, you need to make sure your client's aware and be like, and say something along the lines of, I won't palpate I won't touch the injured spot yet, and I'll let you know with plenty of time before I do. Just you want to give them a heads up so they're prepared and not tense, because if the patient's tense, it's going to throw off your abdominal assessment. Then you're going to do a liver palpation bimanually. So the client's going to lie supine, and you're going to take your hand flat like this and put it parallel with the skin by the liver, right below the right rib cage, and have the client take a deep breath in. And when the client breathes in, you're going to push down and you're going to push in. This is palpating for the liver. A healthy, normal-sized liver is non-palpable. So if you do feel the liver, it's enlarged, which is dangerous. Then after that is liver hooking. So you take both your hands and you kind of form a hook with them, and you go over the right rib cage and you hook around the bottom of the rib cage. Client breathes in, you push down and in, or in and up, sorry. And this is again palpating for the liver. Any pain besides the pain that you're giving by pushing, and if there's enlarged liver. Then is robbing sign, and that's moving on to appendicitis. So if you have symptoms of appendicitis, which is in the right lower quadrant, you don't want to palpate over it, because if it is enlarged, inflamed, you could perforate it and cause more damage. So what they do is, over the left lower quadrant on a 90-degree angle, you simply push down. And if they have an appendicitis, they will feel pain. When you push in the left lower quadrant, they will feel pain in the right lower quadrant. It's called rebound tenderness. After that is the psoas sign, and the psoas sign is for appendicitis also. And the client lies on their left side and hyperextends their right leg. And when they do this, if they feel any sort of discomfort or pain, it usually means appendicitis, because a healthy person can hyperextend their leg. The obturator sign is when the nurse is supporting their knee and their ankle, the patient's knee and ankle, and then they flex the hip and knee, and then they rotate the knee and ankle, like the leg in and out like that. You don't want to feel any sort of pain in your abdomen, because it could be an appendicitis as well, or perforated appendix. After that is the Murphy sign, and the Murphy sign is going back to the liver, and it's very, very similar to the liver bimanually palpation. While the client is lying supine, right below the rib cage on their liver, you take your hand, and the difference is where for the bimanual palpation, you push down and in. This is more just pressing down. So, you just want to press down, and if you feel any sort of pain, it could be of the it could be at the right, not the right, the gallbladder. So where the liver palpation bimanually, that's looking for an enlarged liver. When you do the Murphy sign, which seems very, very similar, you're looking for a gallbladder, an enlarged gallbladder for issues with the gallbladder. So that's the abdominal assessment and how you do it.